Welcome back to the deep dive. So when we think about universal healthcare, Canada's system, Medicare, is almost always the first one that comes to mind. It's famous for this core promise, right?
Yeah.
Access to care, no matter how much money you have.
It really is a landmark system. But here's the thing, there's a paradox at its core. Its global reputation is for being, simple and unified. But that completely masks this fiercely complex, really decentralized structure.
Like people say Canadian healthcare and think it's one single thing.
Exactly. But they're actually talking about this massive collaboration between 10 provinces, 3 territories, and the federal government.
And that complexity is exactly what we're here to unpack today. Our mission is to cut through some of those myths and decode how it actually works, how it's funded, how services are categorized, and how those big decisions are made about things like expensive new drugs.
At its foundation, the goal is pretty clear. It's about fairness and equity, making sure all Canadians and permanent residents have free access to what they call medically necessary care. Hospitals, doctors, diagnostics, that's the heart of it.
And here's the detail that I think trips up most people, especially from outside Canada. The system is publicly funded, but privately delivered.
That's the one. Think of it this way. The government pays the bills for the operation, but it's an independent doctor in a non-government hospital who actually performs it.
Okay, so the federal government sets the ground rules, but the provinces and territories are the ones actually running their own health insurance plans.
Precisely. And that's why a service that might be covered in, say, Alberta isn't necessarily covered in the same way in Quebec.
Okay, let's get into it. We're going to walk you through the whole system, from your local doctor all the way up to cutting-edge research hospitals. Then we'll follow the money. And finally, we'll look at how Canada tries to control drug prices and access. So let's start with how care is classified. You can't really get your head around this system until you understand this fundamental split. There are 2 big streams of coverage based on what the provinces legally have to cover. What are they?
We call them essential services and supplemental services. Essential services are basically what we just mentioned: the doctor's visit, the hospital stay, an x-ray, all the medically necessary stuff that the province has to cover for its residents under the Canada Health Act.
Okay, so if I break my leg, the hospital, the surgery, that's all covered.
Yeah.
But then we get to the supplemental services.
Right. And this is the part that often catches people by surprise. Supplemental services are everything that falls outside that mandatory core. We're talking about prescription drugs, dental care, vision, ambulances, even long-term care. For most people, you're paying for that out of pocket or through private insurance from your job.
That makes so much sense now why prescription drugs are such a huge contentious topic in Canada. If they're not part of that guaranteed core, it means millions of people are relying on, a patchwork of plans.
It's a perfect example. The system is universal for basic needs, but for everything else, it's this hybrid of public programs for certain groups and private coverage for others.
Now let's look at how the delivery is organized. This is based on complexity, and there are basically 4 distinct levels you move through.
It all starts with primary care. This is your entry point, your health home. It includes your family doctor, nurse practitioners, even your local pharmacist. The goal here is pretty broad, from managing chronic illness to disease prevention and, crucially, coordinating your care through the rest of the system.
And if that primary care provider thinks something more is going on, they bump you up the ladder to secondary care.
This is your specialized care, and you usually need a referral. Think of cardiologists, oncologists, or an orthopedic surgeon for a standard knee replacement. This is the kind of care that makes up most of what happens inside a general hospital.
Okay, then moving up from there, we get to the more intensive stuff, tertiary care. What makes this level different?
Tertiary care needs highly specialized people and very sophisticated equipment. It's usually based in large academic hospitals, so think of specialized burn units, neurosurgery, things like that. Services you just won't find at your local community hospital.
And at the very top of the pyramid, quaternary care. How is that different from tertiary?
If tertiary care is the most specialized care that's widely available, quaternary care is the absolute cutting edge. It's often experimental, maybe involving diagnostics that only exist in a few places in the world. A hospital like Sick Kids in Toronto is a perfect example of a quaternary care center. It's where medicine meets advanced research.
Okay, so understanding that journey from primary to quaternary really sets up the big question. Who pays for all of it? Let's follow the money. It's publicly funded, so it's all coming from taxes. How does the federal money get to the provinces to deliver the services?
The main pipeline is something called the Canada Health Transfer, or CHT. This is a huge per-person payment the federal government sends to the provinces and territories. It's a conditional payment specifically for healthcare,
Conditional meaning.
meaning it's the federal government's main lever to make sure the provinces are following the rules of the Canada Health Act.
So the federal government basically writes a giant check and says, here's the money, but in return, you have to keep basic services universal and accessible. And the provinces top that up with their own taxes, like sales tax or income tax.
That's the model. And there's this constant tension, the provinces always need more money from the CHT to cover rising costs, and the federal government wants to make sure that money is being spent effectively. It's a never-ending negotiation.
So if we look at where all that money, public and private, actually goes, it tells a really interesting story about what the system prioritizes.
It does. On the public sector side, which is about 72% of all health spending, the priorities are structural. The biggest slice of the pie goes to hospitals, then physicians, and then prescription drugs, which makes sense since the public pays for the buildings and the core staff.
But then you flip it and look at the private sector, that 28% that's covered by private insurance or, our own wallets.
And the ranking just completely inverts. In the private sector, the number one expense is prescription drugs, by a lot. Then comes dental care, then supplemental hospital services, like a private room, and then vision care.
Wow. That really shows you that drugs are the biggest cost that the universal system doesn't automatically cover for everyone. I mean, what's driving these costs up across the board?
Well, there are a few big things. First, an aging population that just needs more complex care for longer. Second, those innovative and very expensive new drugs and technologies. And a third, more subtle one, is defensive medicine doctors ordering extra tests just to be safe legally, which adds up.
It feels like a constant upward pressure. Are there efforts to contain those costs?
Oh, definitely. The whole system is trying to pivot towards being more efficient. So more focus on preventative health, using technology like telemedicine and electronic records to cut down on waste, and trying to keep people out of expensive hospitals if they can be treated safely elsewhere.
Okay, we've established that the provinces cover most people, but the federal government had some direct responsibilities too. It steps in to cover very specific groups. Who are they?
The federal government directly provides health services for serving members of the Canadian Forces, for inmates in federal prisons, and for some resettled refugees through a program called the IFHP. But the biggest and most significant program is the Non-Insured Health Benefits Program, or NIHB, for First Nations and Inuit individuals.
And the NIHB program is so important because it covers many of those supplemental services we talked about.
Exactly. The NIHB is very broad. It covers pharmacy benefits, dental, vision, mental health. It even covers transportation costs if you need to travel to get care that's not available in your community, which is absolutely vital for people in remote areas.
Now, switching gears a bit, outside of hospitals, provinces also fund a whole range of other specialized settings. What's the difference between them?
So you have long-term care facilities, or LTC homes. They're provincially funded and regulated for people with chronic illnesses who need 24-hour nursing care. Then you have hospice homes, which are all about palliative and end-of-life care, and also group homes, which provide care for kids under 18 with complex health or behavioral issues.
And all of those are part of the regulated healthcare system. But there's a really important distinction for listeners to know when it comes to seniors' care.
Yes, this is a crucial point. Retirement homes are generally not considered healthcare settings. They're more like independent or assisted living apartments. They're much less regulated than LTC facilities, and the residents themselves are the ones paying for it. It's a private residential expense.
That's a key distinction for anyone planning for their family. Okay, let's move into the really high-stakes world of drugs and regulation. Canada has this very complex ecosystem to manage data and pricing. Which agencies are giving them the data they need?
Two main federal bodies really shape things here. First, there's Health Canada. They administer the Health Act, and they're the main regulator for drugs and medical devices. They're the gatekeepers. And second, there's the Canadian Institute for Health Information, or CIHI.
And why is CIHI so critical?
CIHI is an independent nonprofit, and their job is to collect and analyze health data from across the entire country. Everything from ER visits to prescription drug claims. And that's the data that provinces use to see how the system is performing and decide where to spend their money.
Okay, let's get to the big one, pricing. This is where Canada really differs from a place like the US. What tools do they use to make sure they aren't paying crazy prices for new patented drugs?
So what's fascinating here is that the value assessment and the price control are handled by two different agencies. First, you have the Canada's Drug Agency, or CDA. They do these deep reviews on a drug's clinical effectiveness and, critically, its cost effectiveness, basically its value for money. Their recommendations then guide the provinces on whether to cover the drug.
So the CDA tells the province, okay, this drug works, but here's whether we think it's worth the price. Then who actually sets the maximum price the company can charge?
That's the job of the Patented Medicine Prices Review Board, the PMPRB. Think of them as the federal price ceiling regulator. Their one job is to make sure patented medicine prices are not excessive. And they do that by benchmarking Canadian prices against a basket of other countries and by limiting price increases, often tying them to inflation.
And that's the mechanism that generally keeps brand name drug prices lower in Canada. What about generics?
For generics, it's a bit different. Prices are controlled by competition and provincial price caps, but the real powerhouse is the Pan-Canadian Pharmaceutical Alliance, or PCPA. This is an alliance of all the public drug plans, and they negotiate prices as one massive buying group. Their collective bargaining power is hugely effective at driving down costs.
Okay, to finish on drugs, let's quickly touch on how they get approved, because it explains why some drugs can be swapped out and others can't.
This is a really crucial distinction. For a generic drug to get approved, the company just has to prove it's bioequivalent to the original brand name drug, that it acts the same way in the body. Once Health Canada approves it, it's considered immediately interchangeable. A pharmacist can just swap it out.
But that all changes when we talk about biosimilars, which are these huge, complex biologic drugs.
It's a completely different process. Biosimilars are similar, but they are not identical to the original biologic. Because they're so complex, they need a full regulatory submission with a lot of clinical trial data to prove there's no meaningful difference. And here's the key takeaway for you, the listener. Health Canada's approval does not automatically mean it's interchangeable. The provinces then have to create their own policies about whether to switch patients.
And finally, let's talk about the system's emergency valve. The Special Access Program, or SAP. When is this used?
The SAP is administered by Health Canada, and it's a true last resort. It's used only when all the conventional approved therapies have failed or they aren't suitable or just aren't available. Its whole purpose is to give doctors emergency access to unavailable drugs for patients with serious and life-threatening conditions.
So it's a necessary loophole for very rare diseases or really urgent cases. It's not a backdoor to get new drugs into the country.
Exactly. It is explicitly not for routine use or to get around the normal approval process. It's a 24/7 service, and Health Canada usually responds within a day. Sometimes the manufacturer even provides the drug for free in these cases.
But the critical point here is that just because a drug is accessed through SAP, it doesn't mean it's been approved as safe or effective.
Yeah, that is the crucial caveat. SAP authorization is an emergency access pathway. It is not an opinion from Health Canada on the drug's safety, quality, or efficacy. It really shifts all that responsibility onto the physician who requested it and their patient.
Wow, that was a truly comprehensive deep dive. We've gone from the big picture split between federal funding and provincial delivery all the way down to the 4 tiers of care. And we also pulled back the curtain on those really powerful regulatory bodies like the PMPRB and the PCPA that keep drug costs in check.
You know, when you put it all together, what really stands out is that constant interplay between national ideals and regional realities. You have federal money and federal programs like NIHB trying to create consistency, but the day-to-day delivery and priorities are still very much in the hands of the provinces.
Which leaves a really important question for you to think about. Given the system's commitment to fairness and its reliance on these special federal programs, how can Canada balance the constitutional power of the provinces with the desire to create truly national standards for things like long-term care or universal prescription drug coverage? Thanks for joining us for this deep dive. We'll see you next time.